the same system down there. And by the way, OCD, which has also got high comorbidity with these disorders I've just mentioned, the quality of the anxiety is not fear, it's panic, which is also important for us. It's a loss of control. Psychiatric nosologizing can be recast on the basis of these systems. I just needed to mention that, running out of time. Back to my main theme, which is what are we doing then in psychotherapy? So as I said, our patients suffer from feelings. The feelings mean unmet emotional needs. What the quality of the feeling is immediately identifies what sort of need is not being met. So panic anxiety is absolutely different from fear anxiety. And by the way, there's also, it's no accident that this one responds to antidepressants and this one responds to benzos. They're two different systems in the brain. So the quality of the patient's affect tells us what emotional need is not being met. This patient is doing something, seeking to achieve reunion with an attachment object, and what they're doing doesn't work. This patient is trying to get away from something which is frightening to them, and what they're doing doesn't work. So it's a very simple business. Feelings are what our patients suffer from. And they come to they don't come to us and say, doctor, I'm unconscious of something, will you please tell me what it is? And they say, doctor, I've got this feeling, will you please take it away? Yes. Okay, I'm only too conscious of it. And I think here is a very important distinction between the psychotherapeutic and the psychopharmacological approach. Because when the patient says, doctor, I've got this feeling, can you please take it away? The whole psychopharmacological approach is, well, I'll try. Take this. Let's see if this will regulate the feeling. The psychotherapeutic approach says, no, the feeling means something. This feeling means you're doing something in your life to meet an emotional need, and that thing is not working. What you need to do is learn a different way of meeting that need. That will regulate the affect better. These are not dichotomous. I hope you can see, even with the conceptualization, once we understand what the basic driving forces in the brain are and their chemistries and what the functional purpose of these emotional need systems are, so it's the dichotomy between a psychopharmacological and a psychotherapeutic approach disappears, and the psychopharmacological and psychotherapeutic understanding. And of course, although the drug which treats the affect directly is a symptomatic treatment, as we sadly know, it is symptomatic treatment rather than a causal treatment which changes why the patient is suffering that feeling. That is causal treatment. Many patients are not accessible to psychotherapy. In fact, many disorders are never accessible to the kind of collaborative work that is necessary in psychotherapy. But many patients become accessible through the management of the affects. And so again, even in a very practical way, these are not dichotomous or antagonistic approaches. Now, I'm way over time, so I just want to finish by saying this, coming back to the psychotherapeutic approach. So what are we trying to do there? If you've learned anything from this talk, I hope it'll be this, what I'm going to tell you now. Psychotherapy is nothing more and nothing less than trying to help our patients to learn new ways to meet their emotional needs. That's what psychotherapy is, because the thing that they're doing doesn't work. Okay? Then there's, broadly speaking, and very broadly speaking, two ways of doing this. The first is in regard to what is declarative. You can help the patient in a very cognitive behavioral way to look at what they're doing, to think it through again. In other words, reconsolidate it. Feel your way through this. Is that really the right way to do this? Now you're not a child, you're an adult. You're not dependent, you're not feeble-minded. You're able to think your way through this with my help. And so you help the patient to find new ways to meet their emotional needs. Remember, the affect is your guide as to which emotional need is not being met. And that gives you an idea of what sort of thing should you be helping the patient to relearn to do differently. So that's when you're dealing with declarative procedures, declarative predictions. This is what the patient does. They don't realize that's what they're doing, but they can. If you draw their attention to it, they can think their way through it. There's a lot that can be done that way. This is why CBT has such good results. But it doesn't have such good results with everything. And that's because some of the predictions, some of the things that we're doing in order to meet our needs We don't even know that we're doing them, and we can't know that we're doing them because they are non-declarative. Non-declarative means cannot be thought about. Cannot, ever. That's really important in terms of what psychoanalysts think they're doing as opposed to what they're really doing. Psychoanalysts are specialists in helping with that part of what our patients are doing to meet their needs. Remember, the basic paradigm is the patient's doing something designed to meet an emotional need, but it was designed by a little child who was overwhelmed and did it under emergency circumstances, and then they are doomed to carry on doing that forever. This is Freud's timelessness of the unconscious. Freud says in the unconscious there's timelessness. It means not subject to updating. Freud says in the unconscious there's tolerance of mutual contradiction. That means problem not solved, and so on. So how do you deal with that? If you can't rethink it, and you can't. Non-declarative memories cannot be reconsolidated. That's that. You cannot bring it back into working memory because it's not in images. Can't be thought. So that's, I believe, where the psychoanalyst, what they call transference, is what the patient can look at is what they're doing now. What they're doing now is a derivative of the repressed prediction, the non-declarative prediction. They can't reconsolidate the non-declarative prediction, but they can pay attention to what they're doing now. And that's what we call transference analysis. Looking at why are you doing this over and over again? The patient can re-problematize what they're doing in the present. You can use so-called reconstruction, in other words, an understanding of where this came from, to the extent that you are able to reconstruct some explanation, given the patient's life history, how and why they came to have such a bad prediction. That helps you to understand what they're doing now, but the only thing you can change is what they're doing now. And that's why we focus on the here and now relationship with what sort of patterns of repetitive, maladaptive, not in your own best interest sort of behavior are you doing now over and over again. Use the past to understand the present, but the focus is on the present. If you want to help your patients to find better ways to meet their needs, remember that's about the present. They've got to learn different ways of living now. I keep saying it's the last thing I'm going to say. This is the last thing I'm going to say. So you point out to the patient, here and now, you're doing this, and now you can add, you're doing this in order to meet this need, and can you see it doesn't work? Yes, I know it comes from daddy, but that you can't change. Okay, that helps us to understand why you're doing this now, but please note what you're doing now doesn't work. Oh, I see, says the patient. That's transference interpretation. It's a moment of insight. It's wonderful. That's what we aim for. What happens the next session? The patient does it again. Okay, and they do it again and again. That's because non-declarative memories are hard to learn and hard to forget. So you have to make the same interpretation over and over again, and we call it working through. The patient has to see here, there, and everywhere that they're doing it again and again and again, because the non-declarative prediction doesn't go away. But slowly, this becomes generalized into semantic memory. Slowly, this becomes consolidated into a new procedure, and the hope lies with the fact that it works. That's why the patient will have recourse to the new way of doing things as they consolidate it, because it works better. The old way of doing things never disappears. Non-declarative memories are indelible. So times of stress, and to the extent that this is less consolidated than that, the patient will regress to this. This is why our patients can get worse again. But that's our method. That's how it's grounded in our understanding of how the organ of the mind really works. And it's also why health insurance companies have to learn how learning works. Sadly, you need lots of sessions. That's what I wanted to tell you. Thanks very much. Questions?
Yes, I have a question. And I'm not sure, I don't know a lot about psychoanalysis, for example. But in terms of like the non-declarative memory, in terms of like the id, in terms of the consciousness and reality principle, is there work now or previously being done with how neuropsychoanalysis plays a role in the development of personality disorders? I'm thinking more in terms of like antisocial personality disorder and borderline social personality disorder.
Yeah. So the question is there neuropsychoanalytic work, given what I've said about these non-declarative memory systems, is there neuropsychoanalytic work being done on personality disorders, and I think you said borderline personality in particular. So what I want to say is, first of all, I mean, I've been at it for, you can see I'm an old dog, I've been at it for 30 years, but the neuropsychoanalytic approach is still in its infancy, and it's also been done with hard resistance. You know, the analytic community has not been universally welcoming of this approach. So it's only slowly in recent years that I've got more and more colleagues working together with me on this. So I say that as an excuse for the fact that there's a hell of a lot of obvious low-hanging fruit that needs to be tackled that has not yet been tackled. But my starting point in relation to your question would be what I said earlier in the presentation, you know, that we first of all need to understand I'm not for this boxology. You know, I'm not a DSM guy, and I've explained to you why. I think that the natural kinds that we're dealing with are much more dynamic than the DSM categorization allows for. So when you speak of a personality disorder, you actually, you know, you have a basket within which you have many different things. I don't think that there is a natural kind called borderline personality disorder. So, you know, it depends what you mean by that. But I would start with the affects. Generally speaking, and this doesn't apply to every borderline personality, but generally speaking, you're dealing with protest behavior. You're dealing with separation, distress cascade that I spoke of earlier, and you're dealing with the first phase of it, where the patient still has hope. They still believe that they are actually going to be able to get the object to fit in with what they're going to get it back. They're going to make it do what they want it to do. You know, and it's all about that. So recognizing that that's the need that's not being met, that's the sort of approach that we take. So it's a matter of, and also in relation to pharmacological management, it's understanding what we're dealing with here is panic, you know, and so that would be the starting point of a neuropsychoanalytical approach. But I would be lying to you if I say we have now done X, Y, and Z studies on, you know, how to get ahead with borderline personality disorder. That's the direction that we should be going in my view. Yes, go ahead. Yeah, go ahead.
So I'm having a hard time sort of mapping the first part of your talk, which was about like the conscious id and sort of the unconscious ego, onto your memory schema here, and also understanding where dreams would really fit into,
Okay.
kind of, you know, it's...
Okay, so the question is twofold. The first is, he's having difficulty mapping on what I said about the conscious id, mapping that onto what I'm saying here about the memory mechanisms, which are ego mechanisms. And he's also asking, where do dreams fit in relation to all of this? I've spent lots of time on brain mechanisms of dreaming, so that's a topic that I would love to give you. In fact, when you invite me again...
Come back.
But let's start with the first of your two questions. And I've already begun to answer it by saying what I said. That what I said at the beginning was really about the instinctual affective drive systems. These are id systems. And I've said they're conscious. So, you know, what we say in psychoanalysis, that this is the unconscious, isn't true. So that raises the question, well, in that case, where is the unconscious? You know, because any psychoanalyst, and remember I am one, you know, we know that and cognitive neuroscience says the same thing, that there is such a thing as the unconscious mind, but it's clearly not the same place as the id, so then where is it? That's why I move on to this. And I'm saying that this is the unconscious, this is the preconscious, this is the unconscious, that's the conscious, these are the, in terms of, I mean, the ego, to the extent that the ego is learning from experience, learning how to meet our needs in the world, these are our learning systems. And these are the unconscious ones. So I'm trying to show you where the unconscious is and how it fits in relation to the conscious id. Remember, the id is making feelings which are demands on the mind. You know, I'm a problem, do something. The ego is trying to manage those feelings by meeting the need that lies behind the affect. And that's this business of learning from experience. And in health, you head toward automatized things. I know what to do. That works. I don't need to think about this anymore. That's your character. That's your personality. That's your way, you know, of getting ahead in advertising. But it includes the repressed. It includes some things that we do which don't work. And that is the source of psychopathology, that patients do things which don't work against their own best interests, and they don't even know that they're doing it, and they can't know that they're doing it. And that in turn leads to the question of what do we do about that? And I spoke about psychopharmacological approaches and psychotherapeutic approaches. So that's how the two aspects of the talk link to each other. Well, in fact, that's how the first two aspects of the talk link to the third aspect, which was about this last thing I said. As regards dreams, that really is an enormous, enormous subject. I will just say, when I told you that, oh, by the way, there's our basal ganglia. There's lust. There's seeking. This is the foraging system. Starts in the ventral tegmental area, projects mainly to nucleus accumbens, but also to amygdala, medial frontal cortex, anterior cingulate gyrus. This is the foraging system. It's an all-purpose, it's a very, very interesting system, this. All of the homeostatic affects that I mentioned earlier, all of the body-regulating affects, all of them. So in the medial hypothalamus, you have need detector mechanisms, which, when there's a need, it activates seeking, this foraging. But by foraging, let me just explain what I mean by that. By the way, this has to do with dreaming. You think of a dog, you put it in an open field, what does it do? It sniffs the air, wags its tail, twitches its whiskers, and it explores. That's seeking. It's looking for a good time, you know. It's optimistic, enthusiastic, energetic. It expects that something good's going to happen out there, and I want to get to it. And it's like, and this system is activated perfectly by cocaine. So, you know, if you've ever, I know you've never snorted cocaine, but if you've ever seen anyone who has, you know what I'm talking about. It's like, hey, there's a party tonight. I don't know who's going to be there. I'm going to be there. Something good's going to happen. I don't know exactly what's going to happen. I'm going to get there. You know, it's like, whoop! It's this optimistic, enthusiastic, energetic confidence that something good's going to happen out there. That's what that dog is doing. Okay. Now, all needs, by the way, this, when Freud said there's a libidinal drive, it comes pretty close to this system. It's an all-purpose, and no matter what the itch is, it does the same thing. The solution's out there. And remember, depression is the opposite. Okay? That's hypomania. And this, and the switching off of the system, as I said earlier, that is what despair is. Now, it's a very good thing to have a system like that, because no matter what the need is, it activates you to explore, and then you find what scratches the itch. Ah, that thing I can copulate with, this thing I can drink, you know, that thing I can play with, etc. That's how you learn about how the world works, which, by the way, is also why this system is so implicated in psychosis. Finding cause and effect links and making meaning of the world and so on is what this system is all about. So again, you see how wrong-headed our nosologies are when we start grounding them in the proper natural kinds of the emotional brain. So why am I saying all of this? It's because what my dream research showed is that this is the system that generates dreams. In the mesopontine tegmentum here, there's a structure that generates REM sleep. And REM sleep is a very important thing, but it is not the brain mechanism of dreaming. There's a double dissociation between dreaming and REM sleep. When you lesion that, you lose REM sleep, but you don't lose dreaming. When you lesion this, you lose dreaming, but you don't lose REM sleep. They are two different things. They co-activate. That's because there's the needs which then activate this seeking system. That seeking system is the big driver of dreams. And it's really interesting. I mean, when I say this, please understand, I'm giving you a few sentences because you gave me such a short time to talk to you. But there's tons of research behind what I've just said to you. Lesions here lead to loss of dreaming. By the way, modified prefrontal leucotomy severed this pathway because it reduces positive psychotic symptomatology, hallucinations and delusions. Dreams are hallucinations and delusions. You know, in fact, it was considered a bad prognostic sign if after the operation the patient could still dream. We've forgotten that whole literature. But also PET imaging and fMRI shows this system is switched on full blast during dreaming sleep. Microdialysis shows nucleus accumbens. The release of dopamine is maximal during dreaming sleep. Single cell recordings in the VTA. Burst firing. That's what's going on during dreaming sleep. How the hell does the animal stay asleep? You know, because what this system does is what I just told you. It drives you to explore the world, to meet your needs. So that's a question that we're researching also. How and why it happens is, is really a curious problem. That this system drives dreams is beyond question. In fact, when we give levodopa to our Parkinsonian patients, we push them into psychosis if we give them too much. And how you know you're heading there is the patient starts to have a hell of a lot of dreams. So this system is a positive psychotic symptomatology dream that is producing system. And everything is missing in depression, everything is missing in Parkinson's. There's oomph, there's vigor, there's spontaneity, there's generativity, and so on. That's what that system's for. It drives dreams. Now, all I want to say, I'm going to say two more things. One is, please note, Freud was not on the wrong track about dreams. Okay, I'm not a Freud basher. I'm trying to map these two bodies of knowledge onto each other as far as dreams are concerned to a remarkable and utterly surprising extent. Freud had it right. Dreams are driven by the most basic motor pleasure-seeking, satisfaction-seeking mechanism that there is in the mammalian brain. And Hobson had it utterly wrong. It's like the REM is driven by the mesoponton tegmentum. It's cholinergic, not dreams. Dreams are dopaminergic things. The second thing is to come finally back to your question. So how do I relate this to everything else that I've said to you? Well, there are many different needs, okay? Remember, we've got all these, I've only spoken about emotional needs. There are all the homeostatic needs below that, which are not big ticket items in psychopathology. And there are also sensory affects, by the way, disgust, surprise, etc. I've only spoken about the emotional affects, which are the big ticket. These are the things that are most difficult to learn how to meet in the world. Drives and sensory reflexes are pretty simple things. So you have all these needs. One of them is a need to sleep. And so the animal goes to sleep, and that switches off consciousness, and you go into the state of repose. By the way, a lot of offline memory consolidation goes on there. That's what REM and other sleep mechanisms are about, but that's not what dreaming is about. Now all the other need mechanisms are still active. You need to sleep, but you also have all the other, including the emotional need systems. Any need activates this seeking system. Remember, they all feed into that system. That's why you have the paradox of simultaneously the animal is in a state of sleep and it has seeking, because seeking gets switched on by any need. All of them. Because remember, problems are solved out there. Needs are met out there. And so the seeking system, I believe that the dream happens rather than waking up. So there's an hallucinatory, delusional, motivated behavior in the virtual reality of dreams rather than the animal actually waking up and doing something. This is how you marry, you synergize the different homeostatic needs with each other. That's something that we've researched, by the way. We have very good experimental evidence that that's what dreaming does. Among other things, it protects sleep. But to relate to everything I was saying earlier, so remember, unconsciousness is a good thing. That means needs met, okay? What is dreaming? It's the eruption into sleep of consciousness. It's an affect. There's a problem. And the dream is a managing of that problem. It's a cognitive process of how do I manage this. That's in rough and ready terms how we see it. If I sound, as I say, like a speculator, because I know psychoanalysts have a well-deserved reputation of being speculative, please remember what I'm telling you is based in lots and lots of research. Okay, yes, please.
Just coming on the heels of that, I've been learning a lot about hypnosis. Would you see that in a similar way to dreaming, dealing with non-declarative problems, especially with children, as a way to find better solutions for meeting their unmet emotional needs?
Okay, so
because it works so nicely with them.
Look, in the talk that I've given you, as much as I've tried to cover very wide ground, inevitably there are gigantic swathes of things that I've said nothing about. I spoke to you about affective consciousness, and I spoke to you about cognitive consciousness. That's an oversimplification. Within cognitive consciousness, there's two types. There's what we call primary and secondary consciousness, or phenomenal and reflective consciousness, or access consciousness. Different people use different words for it, but we all agree there's having a conscious cognition, including a perception, a conscious representational state, and then there's reflecting upon the having of that. It's me who's having this, it's thoughts about your experiences. That's what reflective consciousness is about. That, I mean, I'm slightly oversimplifying when I say this, but posterior cortices, for the most part, it's just the having of a second-person consciousness. Prefrontal cortex is third-person reflective consciousness. It's looking upon your own thoughts. It's objectifying yourself. It's reflecting back upon yourself, looking at yourself as if you were just another object. That type of cognition, executive cognition, reflective cognition, ownership, agency, ownership of your own cognition and affect. That's what hypnosis is all about. It's not the only thing. Group behavior also has a lot to do with that, where there's a loss of your own. Freud calls that superego function, by the way. That's sort of reflecting back upon your own, regulating it from an objective point of view, your own behaviors. But so, like EMDR also, there are many different routes into this process that I'm talking to you about. It's taking over it's replacing, the hypnotist replaces the prefrontal cortex of the patient. It's so that, and I haven't had time to go into with you the importance of reflective consciousness in terms of what we do in psychotherapy. But I will just say this, that when Freud spoke about consciousness, he meant reflective cognitive consciousness. And so, this is also why I'm wanting to bring into psychoanalysis contemporary nomenclature and the conceptualization that lies behind it, because Freud, Freud was working 100 years ago. Let's not be too hard on the guy. But they're too simple. Those concepts are too crude. So we need to variegate them more. Likewise, the unconscious. It's actually multiple non-declarative systems. We need to understand how they work. So as we do that, I think we not only ground what we're doing in psychotherapy better on what the evidence is as to how this mechanism works, but it also makes it possible for cross-disciplinary discussions and pollination so that we can actually learn from each other. It's the best I can do in a few words.
Shall we have lunch?
Yes.
Yeah. Well, thank you very much.